Good evening. My name is Bill Schlaff. I'm the chair of GYN at Jefferson, and I'm very, very glad to welcome everyone who's here this evening to what we hope will be a enjoyable, interactive, informal CME activity, but also will be an opportunity for hopefully new friends and as well as old friends from Jefferson to get together and to really try to reinvent and reinvigorate the friendships and the relationships that we've shared over the past numbers of years. The people we've invited to this free CME event are really those that have had a relationship with our department, either as a student, mostly as residents or fellows or other trainees. But our goal here is to use a Zoom platform that we've all regrettably become so familiar with over the past year to bring together our alumni family, but also to provide a service and a value to the alumni family by having our faculty members participate in CME activities that we hope will be of value to a lot of people. The CME opportunities are for free for our alumni. We hope that the instructions are straightforward. If you have any difficulty getting your CME credits, please email me. I think the email will be available at the end. It's william.schlaff@jefferson.edu, or better yet, email Vince because he has nothing to do all day and I'm quite busy. This is the second one of these we've done. Our first was with Paul Jesse, who updated us about new guidelines in treatment of vaginal infections. Our next one will be in May. Norman Rosenblum, Chief of Gynecologic Oncology, that many of you know, will not be talking about GYN cancers, but rather will be reviewing pelvic anatomy, which was a much more popular topic for him to talk about. That date is May, and we'll give you more information about that. We're going to hope, if this all works the way we are informally planning on it, that at the end of Vince's comments, that we'll all have a chance to unmute and video and open a bottle of wine and catch up, share where we are, who we are, and how we can all collaborate more effectively as an alumni family for the department. So I'm going to introduce Vince, who has the distinction of being both a former medical student at Jefferson, class, I think, of 1887, as I remember, or 1990, one of those two. Left for residency and returned in 1994 as a fellow, and has been chief of maternal-fetal medicine for many years. Vince is well known internationally for providing evidence-based guidelines for the care we provide. And this evening, he's going to be talking about evidence-based guidelines for induction and labor management.
Thanks, Bill. Thanks for the wonderful introduction. Just sharing the slides here. Thanks, everyone, for coming. I see a lot of friends, actually, former residents. I know well. I won't mention names, but I hope, like Dr. Schlaff said, we can spend some time at the end, and feel free to ask me personal questions and how come I have no hair and what happened to me all these years since you last saw me. But it's really a pleasure to be with you. I'll try to move quickly through a huge topic, induction and labor management. And again, I've been at Jefferson forever. Actually, I'm proud to tell you that our son, oldest one, will start June 7th as a medical student at Jefferson in just a couple months. So it's really wonderful. It's now, I guess, generations of us, Berghella at Jefferson. I have nothing to disclose. I've been interested in labor and delivery, as you guys know, for a long time. In fact, I've taken call with many of you on the Zoom. I also like to, at this moment, to take a moment to thank the many alumni and friends like you of the department who have made charitable gifts to support the maternal-fetal medicine research in particular in the department, and OBGYN research in general. Each year, the gifts we receive actually provide important fundings for our patient-focused research efforts. You will see that actually pretty much everything I present, well, not everything, but most of what I present was contributed to by Jefferson patients, Jefferson staff, etc. So this is me, 1887, as Dr. Schlaff said, or maybe 1990. We had a class of actually about 210 that soon after the second year dwindled down to 193. We had a very tough pathology rotation. I was the lucky one to survive with many of my friends here who I still keep in touch with. But again, things passes, and except for the huge eyebrows, much has changed, as you can see from this picture. But proud to be at Jefferson for so long. I want to dedicate tonight's lecture to one of our classmates. Most of you probably have not heard, but one of my nicest, warmest classmates, Gary Rosado, who I met really the first week back, I guess, in what it was, July, August of 1990. He was already married there, I remember, to his college sweetheart. He may have had a kid already as a first or second year medical student. He was the son of the chair then of surgery. He was his uncle was the chair of surgery at Penn. He was the nicest of guy. I was no one, and he was super, super nice to me. And Gary unfortunately just passed away a few days ago from brain cancer, from glioblastoma. He had a wonderful family, 3 great kids. They also, one of them, at least I know, went through to become a doctor, an orthopedic surgeon. That too accomplished. He loved life. He was director of general surgery at Jefferson. So carpe diem is the message today, and enjoy every day. Make sure that you do good, as Gary did, to all of his patients at Jefferson for many decades, and to all of us, his friends and family. We do, on the OBGYN side, we have the best profession in the world, and I think that one of the most exciting parts is bringing new life to the world. So I'll be on the positive side, obviously, tonight. And the outline of the lecture is basically to go over induction issues and then to go to the stages of labor, trying to give you the latest findings. I do this as I've done for many years. I've now pretty much completed writing the 4th edition of this book. I can't believe it's the 4th edition. It's now about 20 years I've been involved with this book. The 3rd edition did well. Hopefully the 4th will do even better. And it's a book that probably many of you have, and around the world, many nations and countries use. One of the main messages that we need to get used to be scientists and to change. Meaning, for example, I'm not really for induction per se, but I'm for science. I'm not really for example, 39-week induction, as we'll discuss, but I'm for us being open to change. A couple of 100 years ago, we didn't do any C-section. Now we know those save mother's life, save baby's life. I trained in New York, as Bill said, doing episiotomy on everybody. We don't do it almost on anyone at Jefferson, less than 1%. So the message is really to lead an evidence-based life. I don't know how many of you can put it in the chat if you want, how many of you brush your teeth in the morning? And I wonder why you do it. But if you're wondering that, it's because there are over 70 randomized studies, a beautiful Cochrane review, over 42,000 patients randomized, saying that using fluoride toothpaste, and you have to use the right concentration of fluoride, prevents caries and prevents tooth decay. I used not to floss up to a few years ago, but I don't know if you floss or not. But I want to tell you that based on 35 randomized studies, almost 4,000 patients randomized, you should floss. Because in addition to toothbrushing, using flossing, it prevents, again, periodontal disease, dental caries, etc. So it's really an evidence-based life you should lead. And if you want to know about electric toothbrushes, there's also evidence that they help. So I'll go through labor, induction, etc. with those ideas, keeping science first and foremost, and not providing my opinion, but the data. And for example, in terms of diagnosing labor, I'm going to make the case that using transvaginal ultrasound cervical length is much better. We published this in the British Journal a few years ago now, a review of transvaginal ultrasound cervical length to predict. So somebody comes in at 36, 37, 38 weeks. We have no idea when they go into labor. We actually can tell them now when they go into labor. We can do a quick transvaginal cervical length, as I say, at 37, 38 weeks. If the cervix is about, if the cervical length is about 5 millimeters, as you can see here, they have a 90+% chance of going into labor within a week spontaneously. So we can tell them, don't go too far. You go into labor very soon. If their cervical length is 40 or more, we can tell them you can probably stay at your Ocean City, house. You have a less than 20% chance of going into labor within the next week. So we have actually a series in this journal I am involved in. I hope you're aware of it, and it's doing really well. AJOG MFM, the Pink Journal. We're doing a series of review on labor. We actually have done the first 3, and the fourth on second stage is about to come out. But one of them was on induction on labor, which I'll cover next. We've been involved in research for induction for a long time. And actually, having been involved with the NIH for a while, I've known about the ARRIVE trial for 10 years before publication, when it was first devised. We went and did a meta-analysis of the trials before the ARRIVE trials. There were 5, almost 1,000 women randomized. And we knew even there before the ARRIVE trial that C-section was not increased, the maternal blood loss was actually decreased, and that meconium state amniotic fluid was also decreased. So maternal benefit and fetal benefits. And before the ARRIVE trial, this is a huge meta-analysis from now 7 years ago, 157 randomized studies, over 31,000 patients randomized. We knew back then for induction for preeclampsia or UGR or macrosomia or oligohydramnios or PPROM, etc. So many randomized, we knew that cesarean section is decreased by induction. We knew it before the ARRIVE trial, evidence-based. Stillbirths are decreased by 1/2 before ARRIVE, excellent data, and NICU emission also significantly decreased. So again, maternal and perinatal benefits. Then the ARRIVE trial came out. Of course, that makes a lot of noise in the New England Journal of Medicine. Induction at 39 weeks versus waiting till almost 41 weeks in women that are unfavorable. Bishop score, again, I followed this from the beginning, from the idea. They had a very interesting and important primary perinatal outcome, including death and hemorrhage. And when they looked at the final result, over 6,000 women randomized at the NIH centers, hypertensive disorders, including preeclampsia, etc., 36% decrease, cesarean, 16% decrease. This is almost exactly the same as previously shown, so nothing new. The primary perinatal outcome was actually 20% decreased because of the fancy statistics they did, the p-value of 0.049, which looks significant to you, but was not significant given the interim analysis and other statistical issues. But still, 20% decrease, and respiratory support was decreased. So huge, important trial, which I think confirmed previous data, not really any news, that there are maternal and perinatal benefits to induction, including at 39 weeks. And again, how many randomized studies have we done like this? It's really a difficult, important trial, which confirmed and turned on its head what I knew when I was a medical student at Jefferson or as a resident. C-section actually is decreased if you have an induction. So I think there's a lot to rejoice on this. I will put the ARRIVE trial as this huge cake here, which kind of came on top of a lot of other evidence, kind of reinforcing the party that these kids are enjoying because their moms are healthier and they have healthier births. To the New England Journal of Medicine, then some people, including in Europe, and I'm sure, there's always skepticism about issues like this. People say, oh, the ARRIVE should not arrive in Europe or Asia or, Kansas or whatever, North Broad Street or whatever you want to call it. Here, it's a piece from a European journal saying, hey, our patients are older compared to Revive. They're different. Well, first of all, US people mostly have European descent. If you look at the breakdown of the Arrive trial by Groban and all, if you look at any race or ethnic group, benefit in terms of C-section, didn't matter really what Bishop score you had, didn't matter if you were thin or not so thin. In fact, if Europeans think of themselves as thin, BMI less than 30 did better than BMI more than 30. In age, again, trend here for older doing benefiting even more. And same thing for primary perinatal outcome. Most of the data showing benefit and really not much of a change, no matter how big, old, young, and what color your skin was, which is really reassuring results. They also say in that editorial, what matters most to women is a positive experience in childbirth. So, okay, induction may have all these benefits, but maybe women are not happy. Well, the Arrive trial again, NIH data, pain in labor was less, as you can see here, significantly less. And when they looked at sense of control and patient satisfaction, both in the short term and in the longer term, right after birth or later on, this was better. I like to make these quotes from George Sadie, who was one of the investigators for these trials. Many women who declined to be in the trial did so because they did not want to wait till 41 weeks. And actually, we did a study at Jefferson, again, thanks to some of your support. One of our residents did this, Patience Gallagher, published it in the Pink Journal a couple of years ago. Even as the Arrive trial came out, half of the women wanted to be induced at 39 weeks. And now that number, it's well above half. The response to Arrive has been surprising to me. We have spent decades advocating for thoughtful interventions to prevent preeclampsia and decrease cesarean section rates. If you think about it, those are some of the worst things that can happen, preeclampsia, C-section. Yet when a simple intervention, which is induction at 39 weeks, that is based on biological plausibility, I showed you many randomized studies, lots of literature, prior evidence, and a randomized trial, again, which have all shown a 20 to 40% reduction in these outcomes, we tend to find every reason to discount it, which is a little bit sad if you think about it. Again, more data presented from the Arrive trial and other evidence. If you look at healthcare and costs of induction at 39 weeks, you actually end up having less visits, less urgent care, unanticipated care, less hospitalization antepartum, fewer tests, fewer treatment. Yes, you spend about 6 more hours in L&D, but overall, because you have less C-sections, your babies do better, etc., you have shorter hospital stay. So at the end, this is less cost, as you can see from this, and they have cost estimates in this papers, and also really less work for us. So the patient does better, she's happier, it costs less, and we work less. I think it's a pretty good deal. I call this induction for 39 weeks gestations, as we published here with one of our fellows and our colleagues and in the Pink Journal. And we actually also published with one of our fellows, Emily Oliver, again in the Gray Journal, the premier journal really for clinical research in OBGYN, that if in the US, at 39 weeks, even low-risk women were induced, there would be 883 less stillbirths every year in the US, which made a lot of press and again was published by the Gray Journal. So I don't know if there are any questions, but I wanted to make the case for induction at 39 weeks. I have next to cover induction in general and then labor in general. I don't see any questions. So Bill, if you want, I'll keep going unless you see any questions in the chat.
Please go ahead.
So again, this is one of our books, actually, I just showed you on labor and delivery guidelines. And here's the recent paper in the Pink Journal showing that not only 39 weeks gestation, as I have on the upper right here, is an indication, obviously, for induction, but there are many other indications which you guys all know: chronic hypertension, preeclampsia, diabetes, prior stillbirth, for example. And it goes over, twins, rupture membrane, IUG, FGR, etc. So many, and the evidence keeps on mounting for induction being beneficial for 39 weeks and for many, many other indications. How do you do an induction? I'll go over this quickly, but induction is the #1 studied topic in OB in terms of number of randomized studies and meta-analysis. So there's lots and lots of evidence for what I'm going to say in these slides. You should use a single balloon catheter inflated to 60 or 80 ml, better than 30. Keep it in. There's actually a recent trial that came out in the last week or two. 6 hours is probably as good as 12 hours, or when it comes out. And you should use a double agent, not only the balloon, but misoprostol in most women. Most people use 25 micrograms and do it every 2 to 3 hours. We actually do 25 micrograms and then increase to 50 after that, if the baby is tolerating it. If they have a contraindication to misoprostol, like a prior C-section, then on top of the balloon, you can pair oxytocin. So you start with 2 agents, balloon or misoprostol usually, or balloon or oxytocin sometimes from the beginning. That gives faster, better, more efficient inductions. You can also add member strip ring at the beginning of the induction, which is beneficial. You can actually, which may sound crazy to you, but there are many randomized studies that show with an induction, you can stop the oxytocin when they're active, more than 5 or 6 centimeters. That decreases C-sections for fetal indications because probably the baby doesn't get too much oxytocin, and that's better in labor. If you have rupture of membrane, especially more than 37 weeks, as you know, in the oxytocin is the agent of choice. Sometimes now we induce also, obviously, a 34 plus. And one of the important things that it's in the literature is that you should do it as soon as feasible. They shouldn't wait a day or 2 at home because infections in the mother and therefore later in the baby increase. And you can actually use outpatient balloon ripening in low-risk women. So those without a prior C-section, etc. We have some randomized study data from Jefferson. We're going to publish soon a meta-analysis, but Becca Pierce-Williams, one of our fellows, saying that outpatient Foley ripening is very safe. If you'd actually do a meta-analysis of the literature, there are over 400 women randomized to outpatient Foley. There were no stillbirths, no out-of-hospital births, and those women actually did better than the inpatient. They had less C-sections, and they were more satisfied. You obviously need to do the induction right, and you need to be patient. So once you decide to be labor, to go through an induction, you should keep the woman with the induction agents for more than 15 hours, maybe even better, 18, 24 hours of oxytocin and rupture membrane. So once you rupture membrane and the lady is on oxytocin, the patient is on oxytocin, you should kind of start your watch and should not call a C-section just based on time for at least 15 to 18, 24 hours. This is data.
Vince, there's a question from Keith Brill about the use of Dilapan instead of a balloon. Do you have some data you can share about that?
Yeah. Hi, Keith. Good to hear from you. When I saw your name, I was really happy. No long time no see, but thanks for being on tonight. So there is data on Dilapan, and there are different kinds actually of. There are algae that dilate, obviously, the cervix. I think it's a good alternative, in fact, to using a Foley or Cook balloon. There's just less data, and I think most of us use balloons, but Dilapan certainly seem to be safe and effective. I haven't said this, but if you have rupture of membrane, there is some data coming out soon, actually, for one of our former fellow, Daniel McKean, that sometimes you can increase infections if you're ruptured and you're inducing. So I wouldn't use Dilapan or the balloon if you're ruptured, even if you're not that dilated. It's probably best to use oxytocin if you're ruptured. I hope that answers your questions. Going forward, this is Hopkins data I know this is near the Dr. Schlaff has been at Hopkins. They published actually this in the Pink journal, in our journal, MFM. They looked at the kind of the protocol I'm talking about, using usually a balloon, either Cook or Foley, together with misoprostol and then Pitocin. So kind of the double agent I was talking about, in people that were not more than 3 centimeters dilated. They compare this post-protocol data to pre-protocol, in which everybody was kind of doing their own thing in terms of induction. And when you look at their data, again, just published, I think in February, they found a decreased time from start of induction to delivery by an hour and a half. And I think more importantly to this call, a lot of inductions are for 39 weeks gestation, and that went down from 18 to 14 hours. So induction at 39 weeks, most people have a poor Bishop score. Johns Hopkins in Baltimore, next door, less than 15-hour median time from the time you put the Foley in, the balloon in, till the time to delivery. That's pretty good real world data proving that induction nowadays are great. So another message before I move on to labor is be the change you wish to see in the world. If I remember as a medical student, I actually rotated a Methodist back then. We had a rotation for OB. We did episiotomies. We shouldn't do them anymore. We closed cesarean skin with staples. We did a trial at Jefferson and changed the world. You all close probably with sutures your C-sections, as the evidence supports. We actually stopped using oxygen in labor, which sounds crazy to you, but there's evidence it doesn't work. We now use antibiotics before C-section. My times, there was a big questions, and we now use them before every C-section. We do vaginal cleansing, which we started about 3 years ago, based again on data from Jefferson. We do universal cervical length screening for preterm birth prediction and prevention. Cerclage in some high-risk patients here, which again saves thousands of babies every year in the US. And the list is endless of things that have been changed thanks to Jefferson data, and thanks to all of us being open to new data and new evidence and the best for our patients. So unless there are questions, which I don't think there are, I'll keep on going. We may finish a little bit ahead of time, which is great. I'll keep on going. We did induction now, and now I'm going to go through actual labor. And again, a lot of this evidence is in the Pink journal. A lot of concern about eating in labor, and there are actually 10 randomized studies at least. And this is one of our meta-analysis in the Gray journal. And there's even a trial using unrestricted food intake, so they could eat anything they wanted, versus restricted food intake. There are many other kind of diets that you can use. And if you put all this information together, actually labor is a little quicker, which will make sense. If you have carbohydrates around, your muscle works better. The risk of aspiration is extremely low. And so looking at all this, I think I'm less for what we do nowadays and what ACOG still recommends, but I'm more with the nurse midwives, WHO, and Cochrane, who have as conclusions based on all this evidence that there's really no good justification for restrictions in labor. Women usually don't want to eat a lot in labor, and they're good judges on what to eat or not. But especially at the beginning, maybe at the beginning of an induction even, there shouldn't be much restriction according to the data. They should also be hydrated. Unfortunately, there are not many data on oral hydration, PO hydration. But if you compare more fluid, 250, to less fluid, 150, in this meta-analysis, again, per group of several randomized studies, actually labor is quicker, and there's a decrease significant in C-section. And if you use D5, dextrose, that's even more beneficial in terms of especially quicker labor. So make sure you're hydrated. And again, before you go for a marathon, or during a marathon, you want to keep hydrated. And that's really the data confirming what we knew from sports medicine. As I said, we stopped at Jefferson, and we published quite a bit of data on this. And I have to thank Julie Bird, one of our residents, who actually is the first author on this paper, looking at randomized studies using either prophylactic oxygen in labor or therapeutic, meaning for non-reassuring fetal heart testing. Major JAMA trial from Washington University. And as you can see here, not really any benefit from using oxygen in normal babies or babies under distress, quote unquote, in labor. We stopped doing it. You can consider, after cervical wrapping with the balloon, doing rupture membrane. Again, another one of our studies here, looking at 4 randomized studies over 1,000 women. If you do that after the lady is 3-4 centimeters dilated, the large balloon, 60 ml of fluid coming out, leaves usually the woman 3, 4, 5 centimeters dilated. At that time, if that is low, you can certainly rupture, and the labor will go a little quicker. Another somewhat new and somewhat interesting data set, looking at singleton gestation near a term with rupture membrane. Obviously, if they were preterm, we would give antibiotics. There are trials actually looking at antibiotics for term rupture membrane. And you can see here trends for less chorioendometritis and neonatal sepsis. And if you look at the subgroup of women that actually have more than 12 hours between rupture and eventual delivery, this data gets significant. So I actually have been pushing for considering antibiotic for somebody who comes in as a nulliparous, ruptured, 38 weeks, or cervix you evaluate and it's closed or long. I think antibiotics may help her and the baby. There's data on the peanut ball, which again, a lot of midwife use. We actually just published this in the European journal. Total length of labor is shorter, and they have a higher incidence of vaginal deliveries and less C-section. So I'm all now for the peanut ball, now that I know the data. The birthing ball actually has been studied mostly to look at labor pain, and the birthing ball, which can be used in many different ways, but most of the time the woman sits and bounces, on top of it in the first and even second stage. And they have a little bit less pain by BAS score. So I think there's no detriment from the birthing ball and possibly some benefit. Oxytocin, obviously, we use it for many reasons. It shortens labor. It does not affect modal delivery, same cesarean delivery rate. And as I said before, kind of repeating myself here, you can, if you're doing an induction, stop it later when somebody's active. You will have slightly longer labor, but babies seem to tolerate it better, less cesarean delivery. I will move to the second stage here, unless there are any questions. And again, kind of putting a plug here for UpToDate, which I think it's so important and so helpful in our day-to-day life. I collaborate with UpToDate a lot. And if you guys ever find any errors, which I'm sure there are, any things that can be improved, anything that has not been updated, quote unquote, please let me know, because we can, I oversee about 200 UpToDate titles. It gets 1.5 million hits every day, and it's really a very popular way to manage patients the right way. We went back and forth on pushing. I remember as a resident and a medical student at Jefferson, I think back then we would let everybody push right away. We wouldn't wait at all. Then this data on delayed pushing came around, which is, as you can see here, from early 2000. It seemed like actually, yes, you would have a longer second stage with delayed pushing, but you would push for less time and you would have more vaginal delivery. So at Jefferson, about 15 years ago, we changed, and we will wait for an hour or two before pushing, after complete dilatation. And then Cahill published this very large trial, as big as really as all the other trials combined, and say, no, vaginal deliveries are the same, babies don't do better, don't do worse. But if you look at it, the moms do worse. They have more choreo and more postpartum hemorrhage if you wait. So the meta-analysis here shows the same data, no benefit from delayed pushing, and in fact, some harm in terms of longer second stage, which leads to choreo, which leads to possibly or significantly twice as many low cord pHs. So we are back at Jefferson pushing right away after we are complete. There are data on lubricant, and this doesn't make much of a difference if you use lubricant in labor, so it's not bad, but it's not really helpful. There's data on perineal massage from quite a few randomized studies. This does actually confer benefit in terms of less perineal lacerations if you do it before labor, like in the 3rd trimester, or even better, I think, if you do it kind of in the 2nd stage. Perineal warm packs, I think, should be mandatory as well, because they're associated with less perineal lacerations, less pain, and other benefits, as you can see here, quicker onset of sexual activity. So again, these are my hands on a mannequin on the Hamilton building, one of the newer building at Jefferson, with great facilities at Jefferson, which certainly didn't have as I was a medical student, and we've shown that many of these things are helpful. Some of them that you may do routinely, the evidence is there, and actually hands-on, we can discuss this later, does not seem to have benefits, and in fact may have some harm, surprisingly. The Ritken maneuver, which were again taught in residency, again, no benefit in terms of lacerations and more pain. So I wouldn't do this routinely either. This is one of our former fellows, Alexis. She's now attending an MFM at Brown, and she did the only randomized study in the literature, the only randomized studies, which I'm ashamed is still the only one, on how long should the 2nd stage be. She randomized nulliparous at Jefferson on the 7th floor, ancient labor and delivery that you all trained in. At that term, they all had an epidural. They were randomized when they had more than 3 hours of 2nd stage. So they've gone to 3 hours, they were not delivered. We would either extend their labor another hour or more, or kind of call it and say, if you're low enough, have a operative vaginal delivery, too high, have a C-section after more than 3 hours of 2nd stage. So the results showed that there was a 55% significant decrease in C-section rate if you extended labor. So C-sections went from 43% to less than 20%, significant results, and a number needed to treat of only 4. And when we looked at the numbers, and again, this is a small trial, but the only trial on this important issue, which happens, about 500,000 times every day. And 78 patients, you can see maternal outcomes were about the same, no difference, and neonatal outcomes, as you can see in the slides, were no difference. Obviously, these babies were term and healthy, and had great outcomes in either extended labor or usual labor. So to kind of get to the end, and then happy to open a discussion. I think that the evidence for 39 weeks induction is overwhelming. Obviously, the woman should choose, but she should also be aware of the data showing a lot of maternal and perineal benefits for 39-week induction. We should use 2 agents, which most of the time is a balloon up to 60 cc's or more, and misoprostol, unless contraindicated for the very beginning. You can do it outpatient as well, starting with a balloon only. Don't use miso as an outpatient, obviously, only balloon as outpatient. You can be more liberal than we are with food, and especially with fluids. No oxygen for fetal reasons. Push right away seems to be the best evidence in 2021. Extend the 2nd stage past 3 hours, not to 24 hours, not to 12 hours, but surely you can stand in an hour or 2 if the mother or baby are doing well, even if the mother is still showing signs of progress and wants to. Perineal massage and warm packs both save perineums, so to speak, which, as you know, if you have lacerations, severe lacerations, they tend to be associated with incontinence, anal, and others, pain, lack of sexual activity. So really important to try to prevent those lacerations. I remember at Jefferson, when I came back for fellowship, I think we had over 10, 20 incidence of lacerations, with over 60% incidence of episiotomy. Our incidence of episiotomy is less than 1%, and our 3rd and 4th degree lacerations are few and far between with massage and warm packs. Last slides on the evidence. This is for the last stage, the third stage of labor. We can talk if you want about the fourth stage and what happens postpartum, but again, in labor and delivery, to finish the labor part, there is amazing new evidence from over 140 randomized studies and almost 90,000 women randomized. This is a really major meta-analysis that compared to oxytocin alone, we should actually use either oxy, meso, or oxy and metogen together, even on low-risk women, because this is associated with less blood transfusion, less blood loss, faster recovery, and many other maternal benefits. We also use a Jefferson routinely, tranexamic acid, on women with postpartum hemorrhage, with coagulations issues, with previous. We have a major accreta coming out in a couple of days. We'll certainly use tranexamic acid and probably oxytocin and meso, all three, to try to be on top and prevent. Much better to prevent than to treat, obviously, in general, and in particular here for postpartum hemorrhage. We do delayed cord clamping pretty routinely, especially in preterm birth babies, which, as you know, helps them. There's some decent evidence that cord traction, if gentle, it's helpful, both at C-section and at delivery, vaginal delivery. While uterine massage, amazingly enough, there is no evidence for benefit for either vaginal delivery or C-section. I do it, but again, if you look at the evidence, it's, and this is one of them, this PJOC article, the evidence is not there for uterine massage alone being beneficial. With that, Bill, I think I'll stop there. I thank you for your attention and look forward to a glass of something and to further conversation. Thanks, everyone.
Thanks very much, Vince. Your book, there you go. There's a question from Billy Wieserak. Billy, you can unmute and ask your own question. I don't need to ask it for you. Billy is one of our recent graduates, now a full-time faculty member at Jefferson Abington on our northern campus, teaching residents, hopefully, as well as he was taught as a resident. Billy, you want to share your question?
Thank you for that kind introduction, Dr. Schlaff. Can everyone hear me? My question was, Dr. Berghella, I was, the Green Journal, their email blast that they sent out just featured cervical ripening as well. And one of the trials from last year comparing 12 and 6 hour balloon ripening was specifically with a double balloon. And I was wondering if you could just comment on single versus double balloon induction.
Thanks, Billy, and it's great to see you around. It's an honor, for you having spent your evening listening to me. I really makes me proud and honored. It's great to hear your voice. Hope you're doing well. So there is evidence comparing double balloon to single balloon, and there's no benefit from double balloon. So if you look at that evidence, that's why it's going to become routine to use the single balloon. I'm not aware of evidence that the double balloon is bad for you. So I think if people want to use that, that's fine, but it's usually more expensive. And again, given no benefit and more expensive, people use the single. The 6 hour versus 12 hours Green Journal, I referred to it earlier on. I think it would make sense that since we have so much other evidence comparing single to double, that while that trial was looking at double, the data for single will be just as good. I think that the key is to make it 60 or 80 cc, to make it large enough. Another thing we haven't talked about is traction. And Daniel McKean and others, again, another former fellow, have looked at that, and it's not been published yet, but I've seen the data. And in general, traction doesn't seem to really make much of a difference. So it's more volume, and I would say as of today, keep it at least 6 hours, but more evidence for 12. I see Paul asked how much pushback have you seen for the concept of induction for 9 weeks? If you want, Bill, I can take that question. Thanks, Paul. I am again honored about your question that you do wonderful work. I have not seen as much pushback as I would expect. And again, that's not just me, but many others. I think, so I'll give you my personal perspective. My personal perspective is that I hope never to see a 40 or 41 weeker anymore. And again, you may crucify me, you may not like what I'm saying, but I think the evidence is pretty overwhelming for benefit. And, if I think of a stillbirth, and what a terrible thing is, we had a stillbirth, I know for sure in January, of a 40 weeker in 3 days. And it's just, it was a healthy baby, 7 pounds, no anomalies. It's just, they happen. And I think that, I know, because the evidence is there, that would have been prevented if she was induced. So, and it's true. We do have tens of thousands of patients randomized and showing that. So, if a woman wants to wait and knows the risk, I think it's always, it's always up to her. We do have 40-week deliveries at Jefferson still. I think the midwives here were a great group of midwives, which also came from Drexel and counsel women well, as the generalists do. And I think it shouldn't be mandatory. These are options for women. But I think, as you can obviously tell, my strong advice would be to not wait. I can tell you a personal experience. I guess, we're a small group. As you know, I had 2 older kids who were born at Jefferson, and we waited past her due date. This is 1997, 1999. I know some of you were around then. And, being induced at that time before your due date was terrible. And, Paula ended up stuck at complete dilatation and then could never deliver them, 8.6 and 8.3. It's perfectly fine. They're great. They're healthy. She's healthy and well. But in retrospect, I think if Andrea and Pietro were induced a week earlier, I think we would have had vaginal deliveries and, a little bit less of trauma of a breast infection.
So I guess if I could ask a follow-up. So is that like I've obviously been out of obstetrics for a while. Is this nationwide that everybody's doing 39-week inductions, or is it more we're on the forefront of what's being done and what should be done?
No, I think it's everywhere, Paul. The trial was from Northwestern and, part of the NIH. It's all the big leaguers, in terms of, big academic hospitals. So it's being offered everywhere. I think that, some of us, and some of us meaning, again, midwives a lot, physicians, all kinds of community or bigger or smaller hospitals are offering it or discussing it. And I think we did some studies on national data. As you know, the US has about 3.7 million births. And I can tell you, because we haven't published it yet, but Emily Oliver has looked at this, the number of 40 weeker and 41 weeker in the US is decreasing quickly. 2019 was less than 2018, and 2020 was much less than 2019. So it's happening everywhere.
Martha Thomas from York is unmuted, and I wonder if that's because you wanted to ask a question or make a comment, Martha.
No, I'm sorry. That's a mistake.
Well, it's never a mistake. I wouldn't call it that. Maybe it was just a little premature finger clicking. Other questions or comments?
So I see Bill Fred ask about legal risk of not giving oxygen to non-reassuring fetal status. So again, once you publish the evidence, we all have been on one side or the other of the legal issues, in OB and GYN. And I think, once it's out there, if there is a randomized study from Washington University on not giving oxygen for category 2 and 3, having the same outcomes and sometimes even better outcomes, and it's published in JAMA, that's, I would take that, over tradition. We haven't had any pushback. What has been surprising to me is that the nurses in labor and delivery at Jefferson, again, I've been here for a long time, they embraced it. I thought that they would never give it up, but they actually don't. So unless somebody has, pulmonary edema and is standing 70% because of COVID, and she needs oxygen because of that, we don't use it. Amazing. I don't believe myself saying that, but it happened.
David made a comment in the chat room. David, do you want to speak up a little bit? And I have to tell you that I read your comment. I giggled a lot because I'm taking lessons on how to be Italian from Vincenzo. I'm not doing that well, but I like the eating part.
Hey, David, are you there? Dave?
Hi,
There
Vincenzo.
you go.
How
Hey,
you doing?
good.
Good. Thank you. Great talk,
Thanks.
as always.
Thanks.
Yeah. No, I mean, we were trying to get our people to, when I was at St. Mary's, now I'm up at Abington with Billy. And we were trying desperately to get them to feed people, all the calories they put out too in labor and everything to not feed people, and the risk of aspiration being so small. We used the same numbers you used in your talk. It's a hard sell. I hope you've had an easier time selling it at your institution.
We actually haven't. I think, you hit a sore point. I think, again, some traditions are harder to die. And a lot of this literature has been published in the OB side and not in the anesthesia side. And anesthesia, the societies keep on saying, MPO or clear fluid. So, hey, good to see you. So, so it's been a harder sell. I think the nurses are more convinced, which, as you know, nurses kind of rule as they should, labor and delivery, and I think that helps a little bit. But we still, I think we've been successful only in feeding inductions. At the beginning of an inductions, nurses and anesthesia let us feed people, and as inductions get quicker, and that means that often they end up delivering, with something in their stomach. But anesthesia is not so yet.
Yeah, I found a lot of it too was related to the high BMI issues in this area too, and it makes them a lot more nervous. So I do get it, but there's plenty of low risk people that we could be feeding.
Yeah, I completely agree. Couldn't agree more. I'm glad we're on the same page, after all, different places, but same issue.
Other comments or questions for Vince? Well, I want to do a few things.
There's one last one, in the chat here, Bill. Sorry. Anyone using nitrous oxide in Philadelphia? I'll be here. Some of our hospitals in Vegas are using it. Keith, if you can share that. We actually have discussed it, but we haven't been able. Jason Baxter, who is the L&D director, has pushed for it. I'm not aware that we have been successful in using nitrous at Jefferson. They may be using it actually at Abington and or Jefferson, New Jersey. I'm not sure. But what's your experience?
Yeah. So hi Vince. Unfortunately, I'm still working. I'm on the West Coast, so I just saw my last patient while you were talking.
Sorry.
But I'm out of the room now. So the Dignity hospitals we have here, which are national Catholic-based hospital, they started using it. But then it kind of came out during COVID. So we had to have certain protocols about, is it an aerosolizing procedure and this and that. But they started doing it again. I haven't had the greatest experience with it. I mean, I can't say we have huge numbers, but at least the data that was presented to us at the hospitals looked pretty good. And we really didn't see any harm. But it's not like replacing epidurals or anything like that. I'm just curious what's happening in other places. If I always trust what you say. So
thank you for sharing that, Keith. Good to hear your voice as well. Oh, Dr. Dersher.
Hi, Vince.
Hey, how are you?
I just wanted to share with you, before I retired and we had introduced the nitrous to our ambulatory labor patients, and the success rate was not that great. And having the alternative of the epidurals always at the ready made people just disregard it for the most part. I didn't find it to be a really effective tool.
Interesting. Thanks for that. And good to hear your voice as well. And see you.
Thank you.
Thanks, Bill.
So I want to first thank Vince for sharing his expertise and his suggestions with us. Again, I want to reinforce our upcoming I'm not sure what, but you'll all be getting notice about that. Chris Ahern or maybe Jeff Spencer, who've been really, really helpful, may have that date. Jeff, do you have the date for us?
Yes, that program is on Thursday, May 13th at 7 p.m. And you can register right now at jefferson.edu/alumni events. I'll also put that in the chat.